Right, good evening everybody, a very warm welcome. My name's Mike Phillips, I'm the Interim Executive Dean of the School of Health Science and Wellbeing, and I have not only the pleasure of working alongside Professor Nachi Chockalingam, but also the pleasure of being able to introduce him to you this evening. And I'll just start with a little bit of background, if I may. So, Nachi Chockalingam, who's waiting to make his big entrance in a moment, but for the moment at the back of the room, he's the director of the Centre for Biomechanics and Rehabilitation Technologies and holds a number of professorships, an affiliate professorship at the University of Malta, a guest professorship at the Guangzhou Sports University, and a visiting professorship at Sri Ramachandra University in India. And as of today, he has over 700 research outputs with 231 full research manuscripts. He serves on the boards of and supports several international scientific communities and reviews for several journals and grant awarding bodies worldwide. He's also an associate editor for the Footwear Science, Prosthetics and Orthotics International and Rehabilitation for Musculoskeletal Conditions journals. His research has received funding from various international bodies, including the European Commission and the British Council. His current activities at Staffordshire University focuses on translational research. He's played a pivotal role in bringing various allied health professions to the wider biomechanics and medical engineering communities. He advocates strongly for multi- and interdisciplinary research, promotes gender equality, and takes every effort to support students and young researchers globally. He mentors early career researchers from Japan and Taiwan through to China and India and across Europe, particularly in Malta and the Balkans, and to the West in Brazil and Canada. He's involved in charitable and non-profit organisations to help the wider global community on healthy ageing and assistive technology to aid mobility. And it feels that it gives him an opportunity to give something back to the community. I'm assured that as well as all of this, he does have some occasional moments to sleep and rest, although I've not seen an awful lot of evidence in that since I've been working with Nachi, and I'm sure I can see nods around the room from other people within the department. This evening, Nachi will share how he's part of a consortium of engineers who've come together to share expertise and develop a new low-cost field ventilator with the intention of saving lives in poor and remote areas of the world. A very worthy cause indeed, I'm sure you'll agree. They're doing this through online working and the spirit of collaboration. The team are developing a new respiratory support device with the capacity to save lives of patients suffering the complications of infection, trauma and childbirth. So it gives me great pleasure to introduce Professor Nachi Chockalingam.
Thanks for that, Mike, and good evening, ladies and gentlemen. I can't believe it's been 5 years since we started Profs in the PAV. 5 years ago today, or this week, I'm going to stand in the front because Kitty has told me to stay in the camera view. It's very unusual for me to stand in one place and do the talking. I'll try. So 5 years ago, I was talking about high-heeled shoes and partying, but this evening it's going to be different. And many of you have heard me speak about footwear and diabetic foot and the complications resulting from diabetic foot. Some of you might have heard me speak about scoliosis and other musculoskeletal complications that I work with in terms of orthopedic surgeons and other musculoskeletal practitioners. More lately, we have been working, as Mike said, with the WHO and in terms of assistive technology, working with the Global South. Most of these talks that I've delivered either online or face-to-face, I'm really glad that you're here today and then we're doing it face-to-face rather than online, me sitting in my kitchen table and delivering this talk. Most of these talks that I deliver focused on data or the results of the experiments that we have done. So in that sense, it becomes easier to talk about our results. But this evening I'm extremely nervous because I'm going to try something new. I'm going to tell you a story without any data or any experimental results. So in that sense, I'm slightly nervous. But this story that I'm going to tell you in the next half an hour, 40 minutes, I hope it showcases the spirit of collaboration, the human spirit, and how we get together as a society, as a community, to meet the challenges. So in that sense, I'm not going to talk about the virus itself. On January 11th, 2020, the world recorded its first coronavirus death. That was a 61-year-old man who used to visit the Wuhan wet market. He contracted the virus and he died because of the virus. That's the first ever recorded coronavirus death. As it was happening, people in the rest of the world really didn't see what, and we didn't know that this is going to change the world upside down as we knew it. At that time, we were all doing about our own business. This is a picture from our team meeting, our quarterly research seminar series, where we had visitors from Peru for a project that Rusbe is leading. And in that picture, as you could see, Rob standing in the front and defending some of his research objectives, I think. Whilst we were doing that as a team and exploring new research ideas, on the other part of the university, someone was delivering their inaugural address, and she's here somewhere in the room today. Believe me, that's a nice picture. She's checking whether that water is from the melting glaciers. Whilst we were doing that, and little did I know that things are going to change, and I traveled to, at that time, I should mention, the first ever UK case was recorded at that time on the 31st of January, the week after Ruth's inaugural, I think. And then I went on my usual travels. I went to University of Malta to discuss some of the ongoing projects with one of my long-term collaborators, and went to his office. That's his boss. That's not my collaborator, by the way. And Professor Joe Grima, who I work with on oxidic foams, he spends all his time in the lab, and his boss uses his office. And as I went about going to Malta and discussing my projects, and as I returned to Stoke, things were changing dramatically. People in the Middle East was getting really ill, and the virus was taking grip of Europe. And it was growing, and the things were changing for the worse day by day. That time, on the 11th of March, WHO announced the pandemic, and things were getting worse, as we saw Dr. Tedros coming on our TV screens and saying that it's going to get worse. Things changed dramatically in Europe. People realized the enormous damage the virus was causing. And at that time, we didn't really have clear clinical management plans. And scientists were trying to figure out what this virus is going to do to us. And that time, and our death toll was increasing day by day. Whilst we were doing that, trying to understand what this virus is going to do and how it emerges, we had all of our political leaders come out and then say that we should stay at home. We all obeyed. We all stayed at home. I didn't say anything. Whilst we were staying at home, trying to understand what's going on, scientists and clinicians were working day in and out to understand what's happening. The clinical modelers were trying to work hard to see how many people might die and how we can avoid it. And at that point, the panic button is fully pressed now. There were so many speculations in the media about what's going to happen. People were relating it to Spanish flu, which happened 100 years ago. One group of people were saying that it is going to get worse and it's going to be really bad. The other section of the population was saying, including some of the learned ones, saying it's a normal flu, nothing is going to happen, it's going to blow over. At that point, there were patterns emerging in terms of what's going on in the clinical world and what type of patients are being admitted and what was happening to them. One of the things that I would like to highlight here is the main organ which was affecting at that point, which we knew was the lungs. And we knew at that point that the lungs had fluid buildup, as clinicians call it, consolidation of the lungs. Initial thought process was consolidation happens even in pneumonia or ARDS, acute respiratory distress syndrome. But one thing which is different is the fluid. The viscosity of the fluid was different, and although people were thinking that it's going to be very similar to ARDS or any other respiratory infections, but this was different, and people were trying to understand what was going on. We knew it was affecting the lungs, but some of the established clinical protocols weren't working. People were trying to develop vaccines, and at that point you knew that there were various companies coming out say our vaccines would work, and the vaccine development was well underway at that particular point. And there were various drugs being tested for these particular conditions. But one thing which we didn't realize is a lot of people were being admitted to the hospital, and only one thing which worked and which we knew was to put these people on respiratory support devices. That was the only thing we knew that works. So we had to, everyone who was really ill, really sick, needed respiratory support. And then we realized, even in fully developed economies, fully developed world, we didn't really have enough ventilators to go around. And we started to panic. We didn't know what is going to happen. We didn't have enough ventilators to go around. We didn't have enough acute care beds. Even Trump went out to say that he invoked a law from 1950 to say General Motors should make ventilators now. At that time, it was really grim. The situation was grim. Hospitals around the world were full of ill patients requiring ventilator support. But our ventilators, there was not enough ventilators to go around. So that time, as you could see on the picture, almost every country in the world had recorded some coronavirus cases and deaths. That time, whilst I was at home, I think I was still in office at that time. We didn't, can't remember what we were doing. At that time, I had this email. An email from a good friend of mine who was working for UCL, and he was also working for an NGO. He was working with Frontiers Tech and Department of International Development. They put out a call to a group of us who had contacts with various developing countries, who had run various international projects, to see if we could help identify technologies that we could borrow and adopt for our use here in the UK. At that time, we were setting up Nightingale hospitals. We didn't have enough to go around. So at that time, this email came about. And then I put this idea out to our team of researchers here at Staffordshire University. At that point, we were discussing, Panas was leading a project looking at one of the leading a project to look at the stiffness of tissues. So see if we can learn anything from it. Also, we were looking at other technologies that we have developed, see if we can give something back and then help the people out. That time, I was really trying to use my brain cells, whatever little left in there, to see if I can come up with any ideas. Brian came up with some fantastic ideas. And then see if, and he was willing to use his company, his staff, and help out to develop this ventilator. So Barry and I spoke to him that evening, and then we quickly formed a team of engineers to go with it, which includes some of my long-term collaborators to work with us. Within 24 hours, and we were part of a team, a design sprint team, which was led by University College London. And within 24 hours, Brian came up with this design, which I'll show in a minute. So he went out to his garage, used the wiper motor from his daughter's Ford Fiesta, took it out, and then we developed this prototype within 24 hours. And we knew that our concept works. And when we were discussing this, our concept, we realized it's very similar to other people's thinking. So we are not far off, so we can't go wrong. So we knew our concept works. So at that point, we said, okay, we are going to put this forward to the Department of International Development to see if they would help us develop our concept further. So we put a proposal together, and then that's a group of people. We worked together. RDN is Radio Data Network, which is Brian's company, us at Staffordshire University, and the team at UCL, which is Global Disability Hub, which is funded by the FID, and the technology. So we put forward our idea, and for various reasons, our idea didn't go through the design sprint phase, and DFID didn't support us. This is where, when I mentioned tenacity earlier, comes in. We didn't give up. Because we had come up with this prototype within 24 hours, we knew what the problem was, we knew our idea is going to work. So we didn't want to stop at that particular point. So we continued. So we saw various developments, we saw grim pictures on our TV screens. So we, as a team, we discussed, and within a week, 10 days, Brian went out, came up with a working prototype. So from that little concept device, we came up with a fully working prototype with ambu bag. So I need to explain what an ambu bag or a BVM bag is. So ambu bag, or the thing that you see here, is a little made of plastic bag where the ambulance technicians or the clinicians or paramedics use to keep someone to help them breathe. So we use that bag, and it's the same Ford Fiesta motor from Brian's daughter's car in that machine. So we made that, we had a working prototype. We took it to NPL, which is National Physical Laboratory in Teddington, which is the premier institution for testing any type of devices, and they set our regulations. So we took it to NPL, and as you would hear from Barry, we had a much bigger team working. So NPL tested our device and said that it meets the basic requirements to support someone's breathing. So we did have a fully working model within say 10 days or something like that. And all of those internal parts, as you could see on the picture, is all done by Brian and his assistant in their workshop in the house. We have this working, and whilst we were developing this as a team, our objectives were very, very clear. And having worked with WHO and some of the developing countries for our other projects in terms of diabetic foot or assistive technology, my main thing was to keep it simple. I didn't want anything complicated. We definitely didn't want anything complicated in terms of electronics or software. So if you have software in any machine, then the regulations is going to be very difficult. To make it operational in developing world is going to be difficult. The other thing is we wanted to make it easy, rugged, so that it can be transported anywhere in any type of transport. And the other main requirement for us was we should be able to use it in those kind of situations where we have limited energy resources. So either car battery or a truck battery or a battery or a solar panel, that's what our requirement was. So our prototype that you just saw on the previous screen meets all of these objectives. Now it's for us to see what we can do to the next step. At that time, I'll come back to Barry, I'll introduce Barry in a minute. At that time, I'd started talking to a wider group of people, and this is Commodore Barry Brooks, who's going to tell you a bit about what we did, how we went about, and the people involved in the field ventilator projects.
Good afternoon. My name is Barry Brooks. Nachi has asked me to tell you about the people involved in this field ventilator project and how we came together. As you know, he is a great communicator and is very persuasive. I first met Professor Nachi in 2019 when he joined the Worshipful Company of Engineers. The Engineers Company is one of 115 London livery companies. Many of these companies have been around for hundreds of years, having started as trade associations, such as the bakers, the butchers, or the drapers. Over the years, they developed training programs and qualifications for their trades and gave us apprenticeships and master craftsmen, and supported education, such as founding Goldsmiths College and Haberdashers School. To look after their members on retirement and for others in financial need, they established charities and gave us almshouses. The Engineers Company is relatively new, 39 years old. We are a network of over 300 professional engineers from all disciplines, from industry and from academia. We run technical lectures and visits, social events for our members and our partners, support the Lord Mayor of the City of London, and, most important, support education with prizes for engineering excellence, bursaries for engineer undergraduate apprentices, and charitable grants for the relief of poverty. Currently helping the charity Just a Drop, building hygiene facilities in a primary school in Zambia. Our field ventilator story started in 2020 when I was Master Engineer, the traditional title for the President or Chairman of the Engineers Company. The government had called for engineering to help tackle the COVID pandemic. One of our engineer liverymen, Dick Elsey, set up a consortium of 20 large engineering companies, the Ventilator Challenge UK, and built 15,000 ventilators for use in the UK's intensive care units. Separately, Nachi saw a call from the Department for International Development for a low-cost ventilator for use in low and middle-income countries, and asked me if the Engineers Company could help. I shared the request with our 300 members and had an instant response. And that is the story that Nachi is describing to you tonight. And I shall summarise the people who are helping us with this project. First, liveryman Brian Back is an entrepreneurial practical engineer who runs his own micro company, designing and manufacturing electromechanical systems. In one weekend, he designed and built a proof of concept mechanism for a ventilator. Through another liveryman, I persuaded the National Physical Laboratory at Teddington to test Brian's prototype, and they confirmed that the concept was worth developing. Another liveryman volunteered to use his company's resources at their cost to develop the design and build prototypes. This company is an international engineering consultancy with staff around the world. As well as funding the work, they have provided a senior engineer in the UK to oversee the project, a French engineer to be the design architect and project manager, a team of 6 mechanical and electrical engineers in India to design and build the first prototypes, an environmental test house in the Czech Republic to test the device for robustness, a Russian safety engineer based in Germany to ensure that the design is safe, and an American specialist in medical regulatory approvals to prepare the necessary approvals in Nigeria for the clinical trials. As well as this engineering design effort, we've also drawn on other liverymen. Liveryman David Knight, who works for Field Fisher, a legal firm in London, provides advice on intellectual property and contract law. A past master of another livery company, the Insurers Company, put me in touch with the senior insurance specialist in Lloyd's for advice on professional liability insurance for medical devices. Liveryman Clive Hickman, Chief Executive of the Manufacturing Technology Centre at Coventry, agreed that making prototypes would be a good exercise for his apprentices, and they provide us with advice on manufacturability of the design. The MTC are now looking at simulation techniques to help with the next iteration of the design. Clinical expertise has been crucial. Nachi has engaged his numerous clinical contacts around the world to provide us with their specialist advice. The hospital in Nigeria waiting to undertake clinical trials, and several intensivists and anaesthetists here in the UK, the USA and in India, particularly those with experience of the needs for respiratory support in rural areas in Africa. Overall, more than 60 people around the world have come together altruistically to help us to deliver a low-cost, locally manufacturable field ventilator to save lives in remote areas of the world where there is no such respiratory support available. There are lots of lessons from this project so far. Turning the simplest of concepts into a safe and viable medical device is not so simple where the work is done remotely by part-time resources and at minimal cost. Nonetheless, it is heartwarming and inspiring to discover the huge range of expertise and contacts that our engineers livery company and other livery companies have to offer and are willing to share, and to find the readiness of so many people to volunteer their time and expertise to help others. To see the commitment and perseverance of everyone to ensure that we can and will deliver a field ventilator that will save lives that would otherwise be lost. And all this effort to help others in need has been led and guided by Professor Nachi.
I literally gave a couple of hours for Barry to do that video. There's going to be another video, which is even I gave someone else even shorter time to prepare that talk. Now, as Barry outlined, we suddenly from a handful of us, the project grew into a much bigger global project. But it is important that we went that way because we realized that we need more support in terms of understanding the safety features and other aspects. So our team grew much bigger, and the last count when we had, it was 63 people working across, as Barry mentioned, France, India, the US, Australia, and here in the UK. And wider team, and again, the multidisciplinarity. We had clinicians who were advising us, engineers and scientists working around various aspects, safety aspects, and also development aspect of the machine. And last but not least, we had David Knight and his team from Field Fisher advising us on IP, along with the other. That's one thing that we need to realize. There are some negative stuff which might happen, so we need to be making sure that we are covered in every aspect. So we wanted to make sure our contracts, our IP, and everything is protected in that sense. So we had a huge team of people, and we were progressing with the further development of our device. Whilst we are meeting almost every 2-3 times every week in the evenings, as Barry mentioned, all of us were working pro bono after our work hours, trying to get this device going and to help our global society. The cases were still rising and the waves were coming and going, and every country had their own second wave and things were happening. At that time, we started to see that the vaccines are being developed, and we saw some light at the end of the tunnel. We had vaccines fully arrived, and December 2020 saw the first vaccines being delivered to the patients. And then that showed that, okay, at that time, we also had some drugs which were working. So the requirement for ventilators was coming down. We still wanted more ventilators, but the focus changed from the requirement of ventilators to drugs and vaccines. And at that time, I'll come to another friend of mine in a minute. Through our global collaboration and endless evening meetings that I just mentioned, our main thing was to develop this machine with locally available materials. So what you see up on screen is the machine as it stands. So from a wiper motor, still this machine uses wiper motor. And all of those, although it looks complicated on screen, everything can be resourced in any part of the world. And it can be manufactured in a local workshop in any part of the world. So that we still kept our original objectives. So we had this machine. Now it has all of the safety features. It can deliver the respiratory support for a needy patient. But the focus slightly changed from being a respiratory support device or a ventilator for the pandemic to keeping people alive. And I'm a great fan of frugal innovation. Some of you might have heard me speak about frugal innovation in the past for our work with assistive technology and our work with the WHO. So either in the rural parts of Africa or in war-torn countries like Afghanistan, or on the right-hand side picture is a mountainous region in South America. In those remote parts, still healthcare is an issue. And when we call for action in terms of global health for all, we still need to make devices which helps every individual in our global society. In that sense, frugal innovation becomes really important. We have to do better with whatever is available. So in that sense, going up to that idea, we were looking at various aspects as an academic as we do. We started doing research. We did quite a bit of research around the global need. And that's one of the papers that we published. In that context, we looked at what's the need, whether the low-cost ventilator is needed, and whether it has a place. One of the things that we found out is definitely, in terms of, you would hear from Tom in a minute, but before that, there's so many people unnecessarily die during childbirth or during road accidents or in places where snake bites happen. People die because that they don't have access to the respiratory support device. Say, if you could see some of the statistics that I've shown, it's about 138,000 people every year die because of snake bites. And many of these people can be saved if they have immediate respiratory support. Similarly, in terms of road traffic accidents, otherwise these people would be perfectly healthy. If we can keep them alive until they have appropriate care by appropriate respiratory support devices, they don't need to die. So our focus changed from pandemic to keeping people alive and helping people in the needy regions of the world. So here is Dr. Tom Powell, another friend of mine who's been helping with the field ventilator, who's the better person to talk about the need for respiratory support device than me.
Evening everybody, my name's Tom. I'm a consultant anaesthetist working in Salford Hospital in the UK, but I've been asked to speak to you today because of my experiences working in austere environments, predominantly in Ethiopia and in South Africa. In Ethiopia, I helped establish a critical care service, and I've also gone back there to help them develop very specific surgical programs. Now, the idea or the issue of COVID that has dogged us for 2 years has really brought the idea of medical treatments to the front of people's minds, and particularly during the first wave, the idea of ventilators. I also hope that it has highlighted the principle that the ventilator by itself is not sufficient to deliver good healthcare, and that in order to do that, you need personnel, that is medical personnel who are trained in order to administer the treatment, but also personnel who are more behind the scenes in terms of installing and maintaining equipment. A large degree of infrastructure that the equipment has to be plugged into in order to work properly and work reliably 24 hours a day, and also the actual technical equipment itself, which needs to be appropriate for the circumstances in which you're delivering it. I also think that the COVID pandemic has brought to the front of people's minds the ethics of access to certain treatments, and that is both within our own society and then more broadly within the world, and that this has a large impact. Now, in order to speak about the scale of the problem, there is a really great resource that I would point you guys to called the Lancet Commission, looking very, very specifically at access to safe surgical services, but within that would certainly include post-operative respiratory support, and the large scale of the problem, I think, is a real barometer for a much bigger issue. Just the headline figure from that is that 5 of the 7 billion people on the planet, that is most of them, do not have access to safe surgical services. And this was really played out in my experiences in these locations. In Ethiopia, the main cause of suffering and death is medical respiratory failure, that is pneumonia, which is about 40% of the people who died there. And then a close second was post-operative respiratory failure from other major operations that people had undergone. And therefore, these constituted by far the largest cause of death. That is, I'm very keen to say that given the context, these deaths were largely avoidable, but it did highlight the need for what I would say is simple, affordable, context-appropriate respiratory support, which has the potential for really changing the way in which people have some of their common medical problems, both medical and surgical, treated. Now, the COVID pandemic has been a springboard for these thoughts, and what I would hope is that if you're here today and listening to this lecture, that as COVID drifts to the back of our minds, these issues stay at the front of your mind, because they were there before the COVID pandemic and they will be there afterwards. It is complicated, and I think that it is not going to be simple to solve this issue, but there is certainly a role for some sort of respiratory support that is particularly suited for austere environments. I hope you enjoy the rest of the lecture. Thank you very much.
Tom is a very good example of someone who's worked in Africa, remote parts of Africa. We did have 2 other clinicians who helped us with our ideas generation. One is Katriona, who's Tom's colleague, who's now in the US. The other person I should have mentioned him earlier, is Surgeon Commander Tim Scott, who's a consultant anesthetist here in UHNM, who is an Army anesthetist who's got plenty of experience in Afghanistan and Iraq. He couldn't be here this evening, He is now with the NATO forces in Norway training. But I should mention his name because he has been advising us on the clinical aspects from day one of our concept. So he's still very much involved in our project. So does Tom and the other clinicians who have been involved with our project. So you would imagine it's not just a concept that we developed in our lab and it's turned into a prototype that we are testing. It is still very much a live development project, which we want to make sure that it is available readily and freely for the rest of the world. I'll come to that free word in a minute. The other thing which I want to highlight this evening is the UN Sustainable Development Goals. So within Sustainable Development Goals, goal number 3 relates to health, human health, and health for all. So basically within this report, it quotes WHO. WHO reports that 94% of all maternal deaths are in the low and middle income countries. Similarly, and as Tom mentioned, in most of these deaths are because of lack of respiratory support. If we can provide these simple devices which can be manufactured in those places at low cost, we can avoid those deaths. Similarly, goal number 3.5 relates to global and UN calls for reduction of the road traffic accident deaths by 50%. And as Tom mentioned, and as I mentioned earlier, many of these deaths happen because of lack of respiratory support. Even if we can make a small dent, we can definitely help these people. And the other one relates back to environment and poisonous gases and everything, which is 3.9, which again goes back to, I can loosely relate to the snake bite and venom that I was talking about earlier. And also, if you look at the target 3B, which relates to medicines and vaccines, the availability of medicines and vaccines, but I can again stretch it to the availability of medical devices. Although it doesn't really specifically say about medical devices, but if we can make these devices easily available and easy to use in these countries, then we would help enormously to meet these UN Sustainable Development Goals. At this point, again, I need to talked about Tom, I talked about Tim. The other important person to mention, which I should have mentioned earlier, is another collaborator of ours in Nigeria. I know Barry mentioned it in his video. And they have been enormously helpful. Cedar Crest Hospitals in Abuja, and they have other hospitals in Nigeria. So they are very much a part of our development work, and they are still continuing to work, and I'm going to talk about them in a second. So our journey continues. It's not just about academic engineering challenge. It's more about the human spirit, as I said. It is about us as a society coming together to meet the societal challenges. We as a university, we as a research community, we are very much involved in developing these. We work with the local community here, and this evening is a very good example. It's not just about our dissemination work, but it is about co-creation. We work with the people to develop and meet those challenges. And more importantly, the story that I mentioned, I told you just now, focuses on the voluntary work and the altruistic effects and of the society. So we had so many of these brilliant engineers, brilliant scientists coming together. It's nothing to do with a day job. They did meet their employers' requirements in terms of doing the day job, but we did meet to develop this device. So where are we and where do we want to go? So we do have a device which meets some of these basic requirements, but we are going back to testing a bit more to make the device slightly less cumbersome, I should say, or lightweight so that it can be deployed in the field. So MTC is Manufacturing Technology Center in Coventry is helping us. And the other important thing is, again, as I mentioned, co-creation and the human spirit. We used apprentices in MTC, engineering apprentices, to make these devices. So that again gives you a feel for these devices are not complicated, can be manufactured at any part of the world. So MTC is helping us with some of those devices. Our team here at Staffordshire University and also the clinicians at Cedar Crest Hospitals in Nigeria are helping. The Cedar Crest Hospital clinicians are on standby to test the devices on patients. We are going through the regulatory approval process in Nigeria and in the US to test on patients. And we are doing some development work in terms of modeling, working with MTC to identify some of these bags. So I mentioned about BVM bags or AMBU bags. These AMBU bags, as you would imagine, many of them are made in China and deployed around the world. And that's one of those things which is available all around the world, but still it has varying designs. So what we want to make sure is identify what types of bags are available and how it can be used and what design modifications do we need in our ventilator or our respiratory support device so that if someone wants to take our design and manufacture it in a mountainous region in South America, for example, what do they need to do? What design change that they need to do? So that's what we are working on at the moment. But otherwise, we're ready and hopefully our device would be available and deployed before the end of the year. Thank you.